This lecture will continue Chapter 45, The Child with Respiratory Alteration. Croup is a viral infection of the upper airway. Although the entire upper or non-reactive airway is involved to some extent in all forms of croup, each type is named according to the anatomic area most severely involved. For example, laryngotracheobronchitis affects the larynx, trachea, and bronchi. In acute spasmodic croup, the larynx is the area of most severe inflammation. In all forms of croup, mucosal inflammation and edema cause narrowing of the airway. This narrowing is more dangerous in infants and young children than in adults because of their small airway diameter and flexible larynx, which is more susceptible to spasm. Symptoms are usually worse at night and better in the day. They may reoccur for several nights and usually last 3 to 4 days. Croup occurs more often during the winter than in other seasons. Croup often begins at night and may be preceded by several days of symptoms of upper respiratory tract infection. The child with laryngotracheobronchitis may have gradual onset and fever along with other signs and symptoms. Occasionally the fever is as high as 104. Children with spasmodic croup do not have fever. Manifestations of croup include the sudden onset of a harsh, metallic, barky cough, sore throat, inspiratory stridor, and hoarseness. It also includes the use of accessory muscles to breathe, a frightened appearance, agitation, and cyanosis. Pause the video and Google croup cough and get a YouTube video where you can hear what that croup cough actually sounds like. The diagnosis of croup is made mainly from observation of clinical symptoms. The goal of treatment is to maintain a patent airway. Children with acute spasmodic croup can usually be cared for at home. Treatment for acute spasmodic croup includes a calm approach and increased oral fluid intake if the child is not in respiratory distress. Taking the child out into the cool, humid night air may relieve mucosal swelling. Crying aggravates the airway obstruction. Children who develop stridor at rest, cyanosis, severe agitation, fatigue, moderate to severe retractions, or are unable to take oral fluids should be seen in the emergency department. For mild croup, a glucocorticosteroid will be prescribed. Remember, your steroids end in SON or SOLON. Children with laryngotracheobronchitis, usually a more severe type of croup, are more often hospitalized than those with acute spasmodic croup. Racemic epinephrine nebulized with oxygen can be given to decrease the laryngeal edema and bronchospasm. The child must be observed closely for changes in respiratory status and should not be treated with epinephrine on an outpatient basis because the effects of epinephrine are temporary. Croup symptoms can recur after approximately 2 hours, so children who receive epinephrine should be observed in the emergency department for at least 3 hours after treatment and should not be discharged if stridor or retractions are present. Antibiotics are not indicated unless a bacterial infection is present. Acetaminophen is given to reduce fever. For children with more severe symptoms, progressively worsening stridor, cyanosis, decreased oxygen saturation, and retractions, hospitalization is necessary. Humidified oxygen and IV fluids are given until respiratory distress subsides and the child can take adequate fluids by mouth. Sedatives are contraindicated because they could depress respirations and could mask restlessness, an early sign of hypoxia. If signs of moderate or severe hypoxia develop, the child is intubated immediately and is transferred to the ICU. Please review the purple nursing care box that covers the child with croup on your own. It has a lot of good information, so on your own, please study that purple nursing care box for croup. Foreign body aspiration is seen most frequently in children ages 6 months to 5 years. Children who play, run, and laugh with objects in their mouth are at risk. Children's curiosity, oral needs, and occasional lack of supervision contribute to the occurrence of foreign body aspiration. Infants and children love to explore and investigate objects. Exploration often includes putting objects into their mouth. Children also have an uncanny ability to remove small parts from toys and find other objects that parents thought were out of reach. Adults might give infants and small children food that they are not developmentally prepared to ingest, such as hard candy, popcorn, uncooked carrots, hot dogs, or peanuts. Latex balloons account for a significant number of deaths from aspiration per year. Please review box 45.1 for a list of common items of aspiration. Most foreign bodies become lodged in the bronchi. The right main bronchus is more common than the left main bronchus because of its anatomic development. Objects lodged in the larynx cause edema and inflammation. In terms of manifestations, immediate signs and symptoms include sudden violent coughing, gagging, wheezing, vomiting, brief episodes of apnea, and possibly cyanosis. After aspirating a foreign object, the child can remain asymptomatic for hours or weeks. If the object is not found and removed, signs and symptoms related to edema and increased irritation and obstruction may develop. Signs and symptoms of laryngeal and tracheal obstruction include choking, dysphagia, hoarseness, croupy cough, stridor, and possibly dyspnea with cyanosis. Coughing, wheezing, unilaterally decreased breath sounds, pneumonitis, and possibly respiratory arrest can indicate bronchial inflammation and obstruction. The diagnosis is based on an accurate history and clinical manifestations along with imaging. Rigid bronchoscopy confirms the diagnosis and might provide an avenue for removing the object. Foreign bodies are removed from the respiratory tract by direct laryngoscopy or bronchoscopy. After the procedure, the child should remain hospitalized for observation of laryngeal edema and respiratory distress. Antibiotics are unnecessary unless respiratory signs and symptoms suggest an infection. Cool mist and administration of bronchodilators and corticosteroids 24 to 48 hours after the removal of a foreign body may be indicated. The degree of obstruction should be assessed to determine the appropriate action to take. If the child is aphonic, not speaking, and not breathing, the nurse should follow guidelines for managing an obstructive airway. Children with a partially obstructed airway are observed for signs of increasing obstruction. After the object has been removed, the child is observed for signs of obstruction caused by laryngeal edema and soft tissue swelling. The child should be placed on a cardiorespiratory monitor. Liquids are withheld until the child's gag reflex returns after anesthesia. Oral fluid should be started slowly and increase as the child tolerates the intake. INO should be recorded. If the child refuses to drink because of a sore throat or is unable to take fluids orally, the physician should be notified so that IV fluids may be started. The parent's knowledge of respiratory distress is also evaluated before discharge. Parental anxiety and guilt are common after an episode of aspiration. In addition to supporting the parents, the nurse assesses their knowledge of safety. Prevention is the key to reducing the incidence of aspiration. Safety is discussed at every well-child visit. Sudden infant death syndrome, or SIDS, is defined as the sudden, unexplained death of an infant younger than 1 year. The exact cause is unknown. It is also referred to as crib death. SIDS usually occurs during sleep. Despite a marked decline in the incidence of SIDS since the AAP issued preventative guidelines, it remains the 4th leading cause of infant death in the U.S. SIDS occurs most frequently between the 2nd and 4th months of life, with 95% of cases occurring before age 6 months. It is more common in boys, low birth weight infants, and infants from lower socioeconomic groups. It occurs more often during the winter months. Although numerous theories have been proposed, the cause of SIDS is unknown. It is generally accepted that SIDS is a result of an interaction between non-modifiable intrinsic factors, developmental maturity, and modifiable extrinsic risk factors. Intrinsic risk factors include genetic predisposition, male gender, and prematurity. Extrinsic factors include prone sleeping position, bed sharing, use of soft bedclothes or mattresses, putting the infant to sleep on an upholstered furniture or adult mattress, and prenatal or postnatal exposure to cigarette smoke and alcohol. Numerous reports from countries outside of the U.S. have found a significant association between prone sleeping position and the incidence of SIDS. The AAP guidelines recommend that infants should be placed on their backs to sleep. Other sleep environment recommendations from the AAP include avoiding bed sharing. It is recommended to put the infant in a safe bassinet or crib in the parent's bedroom for sleeping. The infant should be kept in the parent's room for a minimum of 6 months and ideally for up to 1 year of age. Use a firm mattress fitted specifically to the crib frame. Do not place any soft bedding such as blankets, pillows, or crib bumpers in the crib or bassinet. Sleepwear designed to keep the infant warm can be used. Provide a pacifier for sleep, waiting a few weeks for breastfeeding to be established before introducing the pacifier. Do not put the infant to sleep in a car seat, infant carrier, or swing. Be sure infants who are being carried in a sling have their face exposed and that no fabric is blocking the infant's mouth or nose. Physical manifestations, the principal manifestation of SIDS is silent death. The child may be found in any position and may be clutching bedding. Diagnosis is confirmed through autopsy. Please review the purple nursing care box for the family of an infant who has died of SIDS on your own. Finally, we're going to cover respiratory syncytial virus, or RSV. This is not covered in your text, so you just have the PowerPoints to study from. RSV is a common respiratory virus that usually causes mild cold-like symptoms. Most people recover in a week or two, but RSV can be serious, especially for infants and older adults. In fact, RSV is the most common cause of bronchiolitis and pneumonia in children younger than 1 year of age in the U.S. Symptoms of RSV infection usually include runny nose, decrease in appetite, cough, sneezing, fever, and wheezing. These symptoms usually appear in stages and not all at once. In very young infants with RSV, the only symptoms may be irritability, decreased activity, and breathing difficulties. RSV can cause more severe infections, such as bronchiolitis, an inflammation of the small airways of the lung, and pneumonia, an infection of the lungs. It is the most common cause of bronchiolitis and pneumonia in children younger than 1 year of age. Almost all children will have RSV by their 2nd birthday. People infected with RSV usually show symptoms within 4 to 6 days after getting infected. In terms of treatment, sometimes children may need to be hospitalized if they're having trouble breathing or are dehydrated. In most cases, hospitalization only lasts a few days. There is no specific treatment for RSV infection. So if a child gets hospitalized for an RSV infection, they're just going to get respiratory treatments. We're going to do symptomatic treatment and maybe some fluids, things of that sort. The one sort of treatment that does exist for RSV is only for high-risk infants. There's a drug that's available, palivizumab. It's available to prevent severe RSV illness in certain infants and children who are high risk. It includes infants who are born premature with congenital heart disease or chronic lung disease. The drug can help prevent serious RSV, but it cannot cure or treat a child who is already suffering from RSV. Finally, you have your practice question here. It's about TB, so not at all related to what we're talking about for pediatric nursing, but just a fun TB practice question for you. If you picked answer B, that is the correct answer.